Our first speaker after lunch is Kang, and she's one of our our directors, actually, of the Transcatheter Structural Heart Program. So she's going to give updates on transcatheter structural heart interventions, and so please join me in welcoming Jin to the podium.
Good afternoon. I hope you all had a nice lunch and that I don't put you to sleep. My name is Kang. I am a clinical director of Structural Heart Program here at Mount Sinai Hospital. And today I'll be giving updates on transcatheter structural heart interventions. I have no financial disclosure. I'm going to start with a fact about severe aortic stenosis. In the United States, 50% of patients with severe aortic stenosis will not be referred for treatment. Aortic stenosis is a life-threatening disease, and when we speak to our patients and their families, we always emphasize how this is progressively worsening disease, and it does not get better by waiting. You could have aortic stenosis for years without experiencing any symptoms, but once you start experiencing symptoms of decompensation, there is a rapid decline in mortality and survival. So as you could see in this graph, survival after onset of symptoms is 50% at 2 years and is only 20% at 5 years. So treatment options and timing do really matter. Just because you have aortic stenosis doesn't mean that we need to be treated right away. We start treating aortic stenosis when it becomes severe and when patients are symptomatic. And severity of aortic stenosis is determined by echocardiogram, and severe AS is classified when valve area is less than 1.0, mean gradient greater than 40, and peak velocity greater than 4.0. So what are the treatment options for severe aortic stenosis? Medical therapy does not work. It's a mechanical problem, so it needs to be replaced. So 2 ways to get it replaced, obviously surgical and also transcatheter approach. So first TAVR procedure was performed in 2002 by Dr. Alan Crebier, also known as the father of TAVR. And that is the father of TAVR with his TAVR MPs 2 years ago, back in when we had our valve symposium. This was truly an honorable moment for all of us. And first TAVR was performed in United States in 2004, followed by partner trials in 2007. And first core valve was performed at Mount Sinai in December of 2010 by the famous Dr. Sharma. And FDA finally approved TAVR in prohibited risk patients in 2011. Followed by prohibited risk patients, high-risk patients were approved in 2012, and intermediate risk patients were approved in 2016, and finally, low-risk patients were approved in 2019. So now, TAVR is indicated in all surgical risk patients. Now that TAVR is indicated in all surgical risk patients, TAVR volume has exceeded SAVR volume. Just like how TAVR was introduced for those who couldn't have surgery, now surgery is offered for those who cannot have TAVR. So why is TAVR preferred over SAVR? For obvious reasons. It's not open heart surgery, it's less invasive, no incision involved, no bypass machine, shorter hospital stay. Our patients are discharged within 24 to 48 hours. It's faster recovery. Our patients are back to their full activity level within a week. And also studies have shown that there is no difference versus SAVR in 5 years in high-risk patients, no difference versus SAVR at 5 years in intermediate risk patients, and no difference versus SAVR in 2 years in low-risk patients. So here are the pros and cons between the two. So with surgery, you have less paravalvular leak, less conduction issues, while with TAVR, you have less atrial fibrillation, bleeding, acute renal injury. Obviously, hospital stay is shorter and faster recovery with TAVR, although with SAVR, you have known long-term durability, and also coronary access is easier with SAVR versus TAVR. Just because TAVR is great, not everyone can go for TAVR. There are patients who should really consider for surgery versus the TAVR because for many, many reasons, and these are the patients who should really be considered for surgery. Anyone who's less than 65 years old, anyone who's low to intermediate STS risk with extensive and complex CAD, heavy LVOT calcification, or other hostile anatomy for TAVR, they should all be considered for surgery rather than TAVR. So I have a case presentation that I'd like to walk through with you. I have a 76-year-old male with complaints of intermittent chest pain and dyspnea on exertion for the past 3 months, which has progressed within the past few weeks. Patient endorses constant fatigue and bilateral lower extremity edema with exercise tolerance of half block. Past medical history include hypertension, hyperlipidemia, CAD with previous PCI in 2018, and a former smoker. As a surgical history, he had a cataract surgery, hernia repair, and knee replacement, and he's a retired post office worker who lives at home with his wife. So here are his studies, which echo did show a valve area of 0.5, peak gradient and mean gradient of 127/81, and peak velocity of 5.4 with EF of 68%. And not only severe AS, this patient has severe mitral regurgitation. CAT scan also revealed that patient has severely calcified trileaflet aortic stenosis with high calcium score of 6,907. Carotid ultrasound was not significant, although CAT did show multivessel CAD with left main disease, LAD disease, and RCA disease. So our heart team had reviewed all the studies, and it did indeed show hostile anatomy for TAVR. There was a high risk for rupture and PVL. So, and there was no femoral access. We would have had to plan for alternate access, such as carotid artery access, and 3-vessel CAD, including left main disease and severe primary MR. So here is our decision-making process guide that guides us which way to go. So this patient is 76, fits in the middle. Surgical risk is about intermediate. Although patient is symptomatic, it wasn't frail, but valve morphology was unfavorable, right? And femoral access, there wasn't, so we would have to plan for alternate access. And concomitant valve disease, such as mitral valve disease and 3-vessel CAD, all the red flags are there. So based on this, our heart team decision was for patient to go undergo surgery. So this patient ended up having combined AVR, MV repair, and CABG. So another case presentation that I like to show is a 67-year-old female with complaints of dyspnea on exertion with constant fatigue with exercise tolerance of 1 block over the past few months. Patient reports decreased energy level and intermittent dizziness and activity. Patient has history of hypertension, hyperlipidemia, breast cancer with lumpectomy in 2001, chemo, and radiation as well. And one thing that stands out here is that she's a sole caregiver to developmentally delayed son. So before we did anything, the first thing she said, I am not going for open heart surgery. So we did all her studies, and it did indeed, echo did show severe aortic stenosis with valve area 0.8, peak gradient, mean gradient over 72/39 with velocity of 4.0. EF was normal. CAT scan also showed severely calcified trileaflet aortic stenosis. Carotid ultrasound was non-significant. CAT was non-obstructive. So our heart team reviewed, and it was a hostile chest because she did have a radiation therapy 20 years ago. And she did have absolutely nobody to care for her son and also herself after the surgery. And all she cared about was, who's going to take care of my son? So all this got factored into, and our heart team decision was to offer this young patient TAVR because, again, she had a hostile chest due to radiation therapy, patient's absolutely refusal for surgery, and also lack of social support. So every case is different. Although we have to do what's right for the patient and what's the safest thing for the patient, we also have to factor into their social and their wishes as well. So I'm going to change your gear a little bit, and we're going to talk about mitral transcatheter edge-to-edge repair to treat mitral regurgitation. In the United States, there are about 4 million people living with moderate to severe mitral regurgitation, yet of those, only 1.5% are being treated. That is a big gap there. Just like aortic stenosis, mitral regurgitation is a progressively worsening disease. If left untreated, MR can progress to heart failure and even death. So 1-year mortality is up to 57% if left untreated, and not to mention multiple hospitalizations in between. And these are very sick patients. So etiologies of mitral regurgitation, there are two types of MR, primary MR, which is the disease of the mitral leaflets itself, and the secondary MR is the disease caused by left ventricle and the atrium. So secondary MR patients are classic heart failure sick patients that just comes in and out of hospital. So what are the treatment options for these patients? For secondary MR patients, first line of treatment has been guideline-directed medical therapy, GDMT, but as you know, medical therapy does not treat the disease itself. It only treats the symptoms, right? And mitral valve surgery is still the gold standard of treatment for primary MR, but not everybody qualifies for that. So for those patients who are high and prohibitive surgical risk patients, they're left untreated. So for those patients who are left untreated, there is a procedure called transcatheter edge-to-edge repair using MitraClip. Just like TAVR, it's minimally invasive, doesn't require open heart surgery. We have a venous access. It's a very quick procedure. It's from beginning to the end. It's about 1 to 2.5 hours. But the actual implantation of the clip is about 23 to 25 minutes at Sinai at this time. So it's a very quick procedure, and it's a short hospital stay. Our patients do end up getting discharged the very next day or even the following day. So here are my take-home messages. TAVR is indicated in all surgical risk categories in aortic stenosis. TAVR is safe and less invasive procedure with great outcomes for those who meet the criteria. High-risk anatomy for TAVR in low and intermediate risk patients should be considered for surgery as an alternative. And in primary MR, TEER is indicated in high and prohibitive risk patients with suitable anatomy. And in secondary MR, TEER is indicated after failing GDMT. And heart failure patients who meet the criteria for TEER should be referred and considered for treatment as early as possible. And I'm sure you see a lot of patients, and if you ever have any questions about these patients, please reach out to us. And also there is that infamous TAVR MP email right there. Email us with referrals or any questions. We are always welcome. Any questions? Yes? We are involved in many trials currently, but that one I don't think we are in. We are currently involved in the progressive trial, which is studying moderate AS patients who are symptomatic. We'll see how that rolls, but right now I don't think I know what the trials that you're mentioning about. Oh. Oh, wow. Any other questions? Yes. CAD, yeah. Patient's doing fine. I mean, you know, luckily we have a great surgical program at Mount Sinai. So, you know, these combined surgeries, they're fine. And then recovery is not as scary as we thought it would be. Within couple, like 6 to 12 weeks, I think they're at their baseline, although they're in their 70s. Any other questions? Thank you.